All right. Well, welcome everyone to today's RettSyndrome.org RettEd webcast. This is Paige Nuez, Director of Family Empowerment at RettSyndrome.org, mom to Katie, our beautiful 15-year-old high school freshman who also has Rett syndrome. On behalf of our board of directors and team, we're so pleased to bring you today's webinar. You and your children are important to us, and we believe in supporting your everyday health and well-being on this road while we simultaneously do all that we can to accelerate research. If you visit RettSyndrome.org/RettEd, that's RettEd, to see our calendar of upcoming monthly webinars and webcasts, you'll also see access to past recordings and Q&A documents from our presenters. Before we begin, I'd like to share a few brief tech points on how GoToWebinar operates if this is your first time with us. The audio feed is open only for our presenters, so you don't have to worry about your background noise interfering with the presentation. If you look to the upper right corner of your screen, you'll see a control panel window. We invite you to type your questions in the question field throughout the presentation, and we'll answer them at the end of the slides. If we don't get to your question during today's webinar, we will work with Dr. Sockrider to get all write-in questions answered, and we'll post the QA document to our RettEd webpage before our next month's webcast. If the control panel window is distracting to you, you can click on minimize and then click on it again to expand it if you want to submit a question. And the next point, as I mentioned, is the session is being recorded, and we will post a link of the recording along with the QA document to the RettEd webpage so you can listen again or share with others on your care team. If you're having trouble hearing, please check and turn up the volume on your phone or device. And now I'd like to introduce Dr. Sockrider, Pediatric Pulmonologist and Associate Professor of Pediatrics at Baylor College of Medicine. Dr. Sockrider has a doctorate in public health in health promotion and disease prevention, and she's Chief of Pulmonary Clinics at Texas Children's Hospital. Dr. Sockrider's research interests include patient and family education and self-management of pediatric chronic lung diseases. She's received a number of teaching awards, and most notably for us, Dr. Sockrider is the primary pulmonary specialist for the Rett syndrome and MECP2 duplication clinical care program at Texas Children's Hospital. She just marked 30 years at Baylor and Texas Children's Hospital, so she brings a wealth of experience to us today. Welcome, Dr. Sockrider. If you're ready, I'm going to turn my webcam off and turn the screen over to you now so that you can begin your talk.
Okay.
Okay, so the control should be coming over to you now.
All right. Can you see my slides well?
We sure can. We can see you on your webcam and we can see your slides. Is everybody okay visually? You can just give us a quick yes in the question spot. That would be fantastic. Why don't you go ahead and get started?
Great. Well, it's my pleasure to be here and visiting with all of you across the country. I have worked with many families with Rett syndrome and MECP2, and it is quite a joy and a challenge, and I'm very glad to be part of our team at Texas Children's. I've given this talk to local events that we've had and have updated it, and I hope that it helps you to both think about things that you face every day and also answer some questions that you might have about breathing-related concerns in Rett syndrome. There's a few words that I always like to just remind people of their meaning because they're ones that are at the core of what we think about with Rett syndrome. So apnea is the absence of breathing, and one can think about both central apnea, which is really coming from the brain control center where there's no effort or the child is not trying to breathe, versus obstructive apnea, where one is trying to breathe, but there's some blockage in the upper airway that prevents airflow, and we'll talk about these. Breath holding is a type of apnea episode that can be voluntary, like when you're going to swim underwater in the pool, or involuntary, usually at the end of expiration, breathing out when it's involuntary. Hypoventilation is reduced breathing that results in a reduced oxygen or increased carbon dioxide level in the blood or both. And obviously the lungs' job is to bring oxygen in and blow carbon dioxide out. Hyperventilation is excessive, rapid and deep breathing that may result in reduced carbon dioxide levels. So we can see some of both in Rett syndrome. Finally, aspiration is where one would breathe fluid or some kind of foreign body into the airways, obviously not healthy. Atelectasis is when an area of the lung or a part of the lung can be collapsed because of some obstruction in the airway. And scoliosis is an abnormal lateral right or left shift of the curve of the spine, which can at times impact your lung function and cause some restrictive lung problems that we'll talk about. So to start, irregular breathing is very common in Rett syndrome. Estimates are 60 to 77% of all people with Rett syndrome have irregular breathing, and their classic pattern is to show periods of apnea where they're not breathing, followed by rapid breathing or hyperventilation. And it's said that there are some MECP2 mutations that show more commonly this breathing pattern. There are a lot of mutations, and I won't be able to tell you about your child's mutation, but you can circle back with your own Rett team. This abnormal breathing is exaggerated during wakefulness, and that is a very typical feature. It can be worse when the person is anxious or aroused or agitated, but these episodes are involuntary. And sometimes the events are mistaken for seizures, but this disorganized breathing does not trigger seizures. These are their own kind of event for someone with Rett syndrome. Most of the breath holding episodes we see in Rett are also while they're awake, although you can at times see them asleep. The severity varies widely between patients and for a given patient. And classically, someone will talk about how the child may be there sitting, appearing happy and smiling even, and not breathing. They're holding their breath and they're not in distress, but they may actually appear very blue or cyanotic. These apnea episodes can last from 20 seconds to 120 seconds, which is 2 minutes. And that could lead to a drop in oxygen saturation. And in between these episodes, breathing is typically normal. So you don't necessarily come out of a breath holding episode and feel short of breath or see them working harder to make up for it. This irregular breathing can cause some interference with one's quality of life and functioning. There's been descriptions of symptoms such as dizziness, reduced mental focus, reduced coordination, complicating even basic tasks like eating and drinking. This is one of the reasons that it's important for us to continue to work on ways to treat Rett syndrome and to try and prevent these episodes. For some people, probably less than 20%, the episodes are more impressive with cyanosis, that blue or gray color, or passing out, which we call syncope. And want to distinguish between perioral cyanosis, which is really just a little blueness around the lips, which is perhaps a little more common but not necessarily very serious, versus more generalized blue coloration. There was a big survey that was done of families. Some of you may have participated in it across the country, and 413 families responded to questions about breath holding and about air swallowing or bloating we'll talk about. And they felt that their loved one's daily life was considerably impacted for about 35% of those with breath holding or hyperinflation, so about a third. The exact cause of the irregular breathing really isn't completely understood. It's typically thought to be part of an overall autonomic nervous system dysfunction. This can also cause other kinds of problems in Rett syndrome, like color or temperature abnormalities, cold or blue feet or hands. It also may relate to other brain center control areas of breathing. Certainly, research continues to try and understand better about these breathing abnormalities. There's actually a mouse model that of Rett syndrome with irregular breathing. And we'll talk a little bit at the end about this current phase 3 clinical drug trial, which is called STARS, that is in progress with Sedation, which is a drug that has serotonin agonist and dopaminergic effects. And these are big words for certain chemicals that are in our body and relate to the function of our brain and our nervous system. So there's really no specific treatment right now that's approved for this awake breathing irregularity. And actually, often it's benign. It doesn't necessarily require treatment. Typically, the person will resume breathing without any need for stimulation. Treatment with oxygen is sometimes done, although it may not change the pattern of breathing. One doesn't usually want, though, to have the child rebreathe like breathing into a paper bag, because that actually can make things worse with the hyperventilation. Some medications have been tried, particularly for those more severe cases that have cyanosis with their episodes or very frequent episodes. One of them is buspirone, or Buspar is the brand. It is a mild anti-anxiety drug. It also is a serotonin agonist. And because these episodes can be worse with anxiety, and some of the patients do struggle with that, that's why this drug seems to work at times. Magnesium sulfate has been used, which also is used for constipation. Sometimes opioid antagonists like naltrexone or naloxone are used. And then there's been some reports of dysparamiine, which is an antidepressant. Really, you'd have to circle back with your primary Rett physician, often the neurologist, to think about whether a medication is appropriate to try for your loved one. I actually don't end up being the person who prescribes these the most, because most of the time this is managed by the neurologist who's already seeing the patient, and they see me for other related complications of Rett syndrome we're going to talk about now. One of the things, I wanted to mention is that sleep problems in Rett syndrome are very common as well, and there's certainly been a variety of sleep disturbances that may affect 80% or more of patients, which also means it often affects the family or main caregivers. They can have delayed sleep onset. They could have awakenings in the night with disruptive behaviors. They may have a shortened night sleep time and then increased sleep during the day, which is frustrating if you're trying to go to school. And they have reduced REM, or that deep sleep cycle. They can have breathing problems during sleep as well. They can have breath holding or apnea, either central or obstructive. And people generally breathe more shallowly during sleep, all of us, but if it's exaggerated, then that might lead to some hypoventilation. And if we are concerned about sleep-related breathing problems, then it is wise to think about getting a sleep study called a polysomnogram. Hypoventilation, again, is when one doesn't breathe deeply enough so that you're not exchanging the gases, the oxygen or carbon dioxide, as well as is needed. And this can occur for a variety of reasons, but certainly it may relate at times to muscle weakness in the chest and body position. And usually one is breathing deeper when one is upright. So it's always more exaggerated or worse when one is lying down or during sleep. Obstructive sleep apnea can be seen, and this typically is during sleep. It's not seen in all Rett patients. Certainly people with obesity can have more obstructive apnea, and that would be true of Rett patients as well. Sometimes we see obstructive events with the use of a vagal nerve stimulator for seizure control. And on a sleep study, because of the way they're recording all the electrical impulses, they can actually see the firing of a VNS stimulator and see if it's correlating with any obstructive. Sometimes I work with our VNS team when that comes up, and sometimes adjusting the stimulator settings can reduce that. But it's always a balance, because the patients that are using a vagal nerve stimulator are using it for seizure control that often is because medications weren't enough. So we have to think about that. Often one will note snoring at night. That's worse if you're sleeping on your back. And again, if one is suspicious about obstructive events or snoring, a sleep study is something to consider. If one has obstructive sleep apnea, sometimes it can be as simple as taking the tonsils or adenoids out, which is something that is a cause of obstructive apnea in many younger children. Although we have to think about anesthesia with the Rett patients. Otherwise, obstructive sleep apnea is treated using typically a nasal or face mask with PAP, or positive airway pressure, CPAP or BiPAP, that they wear during sleep. So when would you worry about your child's breathing? Because obviously these irregular breathing episodes, although if someone's around the child that's not used to it might be very impressed, you'll tend to find that you're like, oh, yeah, that's one of those Rett episodes. But if there is more sustained increased work of breathing, like a higher respiratory rate that doesn't stop in a minute or so, retractions, those are the tugging of the ribs, or distress, that might suggest there's some kind of acute respiratory illness or infection. Having frequent generalized cyanosis or blue spells or passing out would be something to bring up and get a conversation about whether some medication is needed. If the patient has chest congestion or chronic cough, that wouldn't be healthy or typical. And snoring or obstructive apnea, as I said, should be investigated. So shifting gears a little bit, swallowing problems and breathing problems are also a concern in Rett syndrome for some patients. Air swallowing, a fancy word is aerophagia, can lead to bloating, and this is estimated in that family survey to be about 40% or more of patients. It's been described more in older patients, and again, the caregiver survey suggested that at least 44% felt there was a negative impact on daily life from this bloating. One can also see at times drooling. We always have a fancy name in medicine, so that is sialorrhea. Drooling can be a part of the problems with the autonomic nervous system. And certainly I have seen patients where the family has a bib and they just manage it. They may have a suction machine. And there are various medications that we think about that we can talk about for this, but sometimes it's just something you kind of put up with. Dysphagia or difficulty swallowing also is common, and it may be only for liquids, and certainly we see some people who can handle solids or puree, but thin liquids that move more quickly through the throat might be a risk for aspiration. The other thing that I point out at times is if someone has significant gastroesophageal reflux and they have swallowing problems, if their reflux is not well controlled, no one knows when stuff is going to suddenly come up the esophagus and hit the back of their throat. And that's a risk for aspiration, because at least when you're eating, typically you know that spoon is coming to your mouth, or you know you're drinking, versus these unexpected reflux events. So we do worry at times, and I certainly have seen people who have had aspiration or aspiration pneumonia from swallowing problems. One of the things we particularly worry about are people who seem to have what we call silent aspiration. And this is something that has been described and characterized in swallow function studies where they use dye, and they'll see that the dye is trickling down into the windpipe, but the person doesn't react. They don't cough or choke when something gets in the airway like you typically would. Aspiration can result in bronchospasm, where the airway muscles spasm, like an asthma attack, wheezing, chronic cough, chest congestion, bronchitis or bronchopneumonia. And over time, if one continues to have aspiration or microaspiration, it can cause damage to the lungs and airways. So it's certainly something we'd like to avoid when we can. It also can cause other challenges to function, such as when you have a seizure or when you have an infection, because if you're already kind of so-so with your swallowing, when you're ill or you're under that kind of stress, you may not protect your airway well. To try and understand how well someone can swallow, we do swallow function tests. These are tests that are coordinated with a radiologist as well as a speech pathologist, and they typically are done with thin liquid, thicker liquid, and then different kind of consistency of solid food to try and assess how well the person is swallowing and what kind of consistency they can handle. So there's certainly some people who can, again, handle tastes of food or can handle puree, but really need some help with liquids. And in those cases, they may need to have a gastrostomy tube placed. And I tell people that, having a G tube, it kind of gives you a way to assure you've got adequate hydration, that you get the calories that a child needs to grow. It kind of takes the pressure off, but it may or may not mean that they can't have anything by mouth. And again, as we weigh and balance sort of the risks and benefits and quality of life, I certainly have some people that their loved ones will enjoy tastes of ice cream or fired Cheetos or whatever they enjoy, but they don't depend on what they have to take by mouth for their nutrition. We certainly provide suction machines if needed for oral secretions. And again, there are some people who have enough trouble with excessive saliva or pooling of saliva in the back of their throat, even when they're not eating by mouth, that we think about medications. So we typically are using medicines that we call anticholinergic drugs. And often these are medicines like the ones listed that they weren't approved originally for this purpose, but because we know that people get a dry mouth with it, that's how we manage to use them, and it helps. We're not looking to completely dry the mouth out. You need some saliva for the health of your throat and mouth and teeth, but you can turn the faucet down some. So glycopyrrolate is very commonly given. It's usually a tablet that's given by mouth or crushed in a G tube. Scopolamine is a transdermal patch people might be familiar with because people use it for motion sickness with cruises or air travel, and they'll tell you that their mouth gets dry. And so this patch can be placed and changed every 1 to 3 days. It's kind of a long-acting, sort of low-level control. Atropine eye drops can be put under the tongue and can sort of act more locally to dry. And sometimes I use those just as sort of an add-on if they need it. I certainly have had even a family that's what they used if they went out to dinner with the family, because in a restaurant it was just handy to not have so much drooling, but they didn't feel they needed a medication that worked it over more time. Impaired airway clearance is the way we describe people who really don't cough well. And certainly there are not many young children who are very good at coughing stuff out, just like they don't blow their nose well. But these are situations where a person really can't get the mucus up to either where they can swallow it or spit it out, or someone could reach it with a suction catheter. And so people will say that they can hear mucus just right there in the chest and that the person's struggling, but they can't get it up enough. And so we have to think about what can we do to help that. And it's okay to swallow mucus that's out of the lungs, but really these are people who just can't get it up into the throat. So this can be caused by a number of things. Scoliosis at times affects the mechanics of your breathing and cough because of how it twists the chest, the thorax. Muscle weakness and poor tone can make one's cough weaker. And then immobility limits your movement of mucus. You know, we don't even realize, as we all make mucus, how it moves up the airways and out all the time. And we're just, you know, not aware of it at all. But if you're immobile, laying around or not moving, then certainly that doesn't help that movement of mucus and how well you breathe. These are some X-ray images that show you atelectasis, and it's easiest to sort of imagine what you're looking at if you think about how air is dark on X-rays and the lungs are full of air. And so in the image that's to the right, where one side is white and the other one is black, that right lung has fully collapsed. It's blocked with mucus, so there's no air in that lung. And in fact, because the left lung is trying to do the job of breathing, the heart's even shifted over to that right side. In the left-sided image, it's not as severe. And in fact, the main white shadow you see in the chest is the heart. But as you look over to the edge and you compare it to the other film, you see how there's a nice sharp angle in the left side on the first film, and you lose that. And you can see too that on the right side, there's a nice sharp angle it's missing. And that's because the left lower lobe has gotten blocked with mucus and is collapsed. So here are some of the things that we do to help prevent atelectasis, to help people clear up mucus. So we use various kinds of airway clearance. And usually we'll tell people that certainly when there's a time when you have a cold or you're sick, that you need to do more airway clearance. So they may do it up to 3-4 times a day, or if someone's in the hospital, we'll do it every 4 hours. I have a number of patients that do see me because of their lung problems that may do this twice a day as a maintenance, in the morning because they've kind of slept all night and stuff is built up, and in the night to help kind of get ready for going to bed. Another device that's used is called a cough assist device. That's the blue box at the top is one example. And this is done together at times with things like the vest or chest clapping. And it's a kind of a strange device because it's got an inspiratory pressure that blows air in to get air around the mucus. And then it has a negative pressure like a vacuum that sucks the air back up. And so by pulling that air up, it's pulling the mucus up and helping a person cough. Like I'm coughing. Unfortunately, some people with Rett syndrome can develop damage to their lungs from pneumonia. There was a study where they did CT scans of the chest in 27 girls who were average 12 years of age, and they found 15 of them had some abnormal changes on X-ray. This damage to the airway, we think, is typically in part due to this difficulty of clearing mucus from the airways. And so people who've had episodes of pneumonia, we certainly want to be very thoughtful about what we can do to help prevent any further injury. A single episode of pneumonia doesn't necessarily give you permanent damage to your lungs, but repeated insults over time can be a concern. So what do I do when my child is sick, and who do I need to talk to? If your home program isn't working well, if you know your child is more congested and things aren't going the way they should, you need to review it with your child's healthcare team. If there's signs and symptoms, your child's getting worse, don't delay. And you should have an emergency plan and sort of an understanding of who do I see, who do I call, when do I go to the pediatrician, there's a fever or earache, when do I talk to my Rett specialist or neurologist, and do I need a pulmonologist, or when should I call the pulmonologist? I was asked to comment about use of a tracheostomy. Certainly it's not something that any parent would want, but occasionally it is something that is done. And as always, we try and think about the risks and benefit. Tracheostomy is a special tube that is placed in the neck that enters the windpipe, and it gives us access to the lungs and the lower airways directly. That can allow for us to be able to suction secretions out or to provide support for breathing with some type of ventilator that is used to help maintain that person either all the time or with sleep. There are ways to use, we mentioned earlier, the CPAP and BiPAP, or non-invasive ventilator support with a face mask or a nasal mask, and sometimes that is enough. But there are times where a person may really need to think about whether a tracheostomy is right, and yet it requires care. It certainly can have complications, and it can limit one's voice. May also affect swallow. There's really preventive measures that all of us should use really all the time, but I always remind people of when they have a family member who's at particularly high risk for struggling with infection. So no one benefits from exposure to tobacco smoke, but I'd be particularly diligent with the Rett patient. Good hand washing is often a key to preventing infection. Getting childhood immunizations is useful, and an annual flu vaccine for the patient and caregivers. The Prevnar 13 is a vaccine for a particular type of bacteria called strep pneumonia. It is actually part of childhood immunizations. If your patient was born, say, a decade ago, they may have only gotten Prevnar 7. So the Centers for Disease Control, if someone only had gotten Prevnar 7, they should get a booster dose of Prevnar 13. So you may want to check your immunization card. You may also want to consider the Pneumovax V23, which is another pneumococcal vaccine that's only used for high-risk people for pneumonia. The numbers, the 23, the 13, refer to different strains. So it's a little broader coverage. It's an older vaccine that's not quite as potent, so that for the average child, the Prevnar 13 is used. But you can give both. You just have to have them at least 8 weeks apart if you've not had either one. Anesthesia and sedation procedures we're asked about at times. Goodness. Things like dental procedures, we usually advise them to be hospital-based, not in the office, that one would give them any kind of sedation, because you really want to have more close monitoring of their breathing. And in surgeries, they need to be observed at least overnight. Like some children might have tonsils and adenoids as an outpatient surgery, but we would typically advise keeping overnight to be sure they recover well from anesthesia. Sometimes you need sedation too with special radiologic studies like MRI, and again, those should be done in a setting where there's very close monitoring. And I was struck when I was doing a new review of the literature at the title of this paper, Peculiar Breathing and Rett Syndrome, an Anesthesiologist's Nightmare. And I think it really probably reflects that people who aren't used to seeing the irregular breathing episodes, when someone's coming out of anesthesia, they're going to be like, wow, what is happening here? So recognizing that it's useful to have anesthesiologists and anesthetists who know what Rett syndrome is, who are ready to monitor and not, get overly excited about breathing patterns that are really just typical and not serious versus times where one might need support. These are some images of scoliosis, and you can see that the spine's got some twist to it. These are ones where it's involving the part of the spine that's kind of up in the chest area. And so depending on how much curve there is, one lung is going to get kind of squished at times, and the chest wall dynamics are different so that there can be some restriction to how well that lung expands. Now, certainly we see scoliosis too, where it actually involves the lower spine and pelvis, which really doesn't affect breathing, but we have to be involved if they need that to be stabilized because of hip pain or difficulty being in a wheelchair. And so by age 16, the prevalence of scoliosis ranges from 50 to 85% in Rett syndrome. And again, there's some mutations apparently that have it more commonly, and they're not ones that I can recite to you, but you can ask your Rett doctor. This develops over time, and so the median age of onset is around 11 years. It certainly can progress more as you move into puberty, which is also true of other kind of forms of scoliosis. They say that scoliosis progression is reduced when there is the capacity to walk independently or with assistance, and I think that really has some reflection of your muscle strength and your truncal tone. But as I say, it can certainly progress, particularly during childhood growth spurts. So I'm not the orthopedic surgeon, the expert on Rett syndrome and scoliosis, but certainly there are some who may benefit from bracing or wearing these kind of thorax jackets for moderate curves. And those that have more severe curves are ones that may consider the need for surgery. And they estimate this with certain angles that they measure that curve. And so this Cobb angle of 40 to 50% is one estimate that might suggest the need for surgery. So when one is thinking about surgery, you really want to be supported well by specialists in anesthesia and pain control and seizures. And you want that person to have get mobilized early, to be up in a chair and things that will help to minimize some of the breathing related concerns. And postoperative respiratory complications are a risk that needs to be managed. Certainly at our center, we have a scoliosis board that reviews cases to see who needs surgery. And then it's a team effort. And so every patient is evaluated ahead of time, not only by orthopedics, but by nutrition and neurology and pulmonary and other specialists if needed. And then pulmonary is involved in their post-op care. There's some evidence that suggests that spinal fusion, that stabilizing procedure, is associated with a reduction in the risk of severe respiratory infection, particularly among those who had early onset scoliosis. So there may be benefits to stabilizing the spine beyond perhaps pain or comfort related things and being able to sit up and be in your wheelchair. So we mentioned earlier this drug trial that's going on. It's called STARS, that stands for Sarazotan Treatment of Apnea and Rett Syndrome. And again, there's no cure for Rett syndrome right now, and there's certainly researchers that are exploring potential treatments to control symptoms. And this drug seems to be promising in the hope that it may reduce the frequency and severity of irregular breathing episodes in people with Rett syndrome. And there was animal evidence that then brought this drug to the point now where it's in this phase 3 randomized clinical trial. The website that you can go to learn about the trial and what the eligibility is and what sites are participating is there on the screen. I know that our site is still recruiting. I'm not directly involved in that clinical trial, but I do know that there's still opportunity for people who meet the eligibility criteria to see about participating. And eventually there'll be answers that come out of that research. And if the drug seems to be showing the benefit they hope, then of course it would go to the FDA for approval and availability to anyone. So in summary, certainly irregular breathing problems with this mix of breath holding and hyperventilation are common in Rett patients while awake. Sleep problems and abnormal breathing during sleep can occur and may require a sleep study to better define it. Hypoventilation can occur with shallow breathing and may be to the point where we have to worry about gas exchange. Swallowing problems can increase one's risk of aspiration pneumonia. And impaired cough and airway clearance can make it harder to handle respiratory infections where you have more mucus. Scoliosis at times can contribute to restrictive lung function, but care is required with any anesthesia or sedation. And clearly more research is needed for treatments and prevention of breathing problems. So I'll be happy to entertain questions, and I hope that this was a nice overview for you, and I definitely hope that we can come up with better ways to help our patients with Rett syndrome in the future.
Thank you so much, Dr. Sockrider. We had the benefit of so many wonderful questions submitted in advance, and I think you covered a lot of territory in your slides. We did have some additional questions come in through the chat function. Some of them you did answer in your slides, but because they are really important to our audience, I want to give you a chance to hit on them again if you would. So when you answer that question, feel free to flip back to the slide in your presentation if that's easy to do. If not, don't worry about it. A verbal is just fine. Okay, so we have a question. A parent is asking, why is breathing so funny when our girls and boys wake up, almost as if they're startled? I don't know if you've seen that in clinic or not, but many parents do describe this happening.
Yeah, I think that, again, these irregular breathing patterns can be triggered by various states. We mentioned anxiety and perhaps just the surprise or just that shift in your state of awareness maybe what triggers it. You know, when we sleep, we go through various stages of sleep or cycles of these very light sleep to REM sleep. And so probably people have had times where you've been awakened in the middle of a dream or REM sleep and you feel a little disoriented. So, you know, you don't always wake up out of the same sort of light sleep state. So perhaps that's going on at times too.
Okay, and if she or he regulates fairly quickly after waking in this way, is it a problem?
I wouldn't think it's a problem. Again, most of these episodes are self-limited, are short, and we really don't do any specific treatment. I think, you know, sometimes parents begin to know kind of how to approach their child and play around with different strategies on how to wake them up so they're not as startled, you know. It's like I choose certain alarms on my cell phone because others are just too obnoxious for me in the morning. So
I'm with you on that one. We have a question from one of our parents in the UK. So the name of the medicine might not be common in the US, but you'll probably know what she's referring to. And her question is, have you found preventive treatment programs helpful for people with Rett syndrome who are at risk of recurrent chest infections? Their daughter is 37, has Foster morning and night, takes a prophylactic antibiotic during flu season, and also takes mucodine daily to keep secretions fluid. They always keep that antibiotic doxycycline at home, ready for use at the slightest sign of infection. And this has started immediately, and the prophylactic one has stopped. And they think that this has really helped decrease the incidence of serious infection and hospital admission. So can you comment on your strategies for care as people age and have had recurrent infections? Are these good practices? What are your thoughts?
Right, so there's kind of two different kinds of, at least, medications that were mentioned. One are the kind of medications that might help in moving or mobilizing secretions. And one thing I didn't mention was there often, a lot of my patients will use nebulizer treatments, mist treatments usually with albuterol and saline. And if one had asthma, typically you'll use albuterol to help relax and open the airways. And a lot of people with asthma now just use inhalers because it's fast. But I find that when you're really aiming to try and thin secretions, using the wet neb with the saline is really the advantage. And we put the albuterol in because sometimes saline can give some bronchospasm. Now, sometimes we'll add other medications in as well. So one, acetylcysteine, it's called Mucomist, is an old drug that can help thin secretions. Some people will use nebulizer treatments with a saltier solution called hypertonic saline. We do this in patients with cystic fibrosis who have very thick secretions, but anybody, if they have a bad cold, their mucus can be thicker. Mucinex, or maybe what she was mentioning, something that you can buy over the counter that thins secretions, may or may not be of much help, but it typically is well tolerated, and I expect generally shouldn't interfere with like seizure meds. And whenever you look at medications that you're going to start, you always want to be sure about drug interactions when you're on other things. The other kind of medications that she was mentioning were about antibiotics, and certainly a lot of infections, and particularly younger kids, but any of us really are viral infections, and antibiotics don't work for those. So there's no antibiotic for the flu, there's an antiviral, but there's definitely no medications for rhinovirus that causes the common cold or RSV. Now, there are people who I have worked with, and we mentioned earlier the CT scan that shows some people who have some lung damage, sometimes damage we call bronchiectasis, where they may be more prone to keeping bacteria in their airways. And so occasionally we'll think about rotating antibiotic or some type of antibiotic program. I don't have a lot of people myself on regular rotating antibiotics. Now, one thing that I've done, and perhaps not as much in Rett syndrome, but might be one of the things she's referring to, there is some protocol for using azithromycin, which is an antibiotic, but it also has anti-inflammatory properties. And I have used it in people where we use it 3 times a week, like through the winter months, or our patients with cystic fibrosis may be on it long term. And it can help manage that inflammation and infection. But there's no antibiotic that covers all bacteria. And that's part of the dilemma, and perhaps even the risk of using a given antibiotic all the time, because you may then select for more resistant strains. And so I think it's a very individualized decision based on that person's pattern of pneumonia and infections, and perhaps even based on cultures that have been obtained either directly from the airway with a bronchoscopy or with some kind of gag sputum or something like that.
Okay, thank you. A parent has another question about a specific intervention, and they're wondering if you ever treat with Pulmozyme, and when, if ever, might Pulmozyme be an effective treatment, and do you use it therapeutically or prophylactically?
So Pulmozyme is alpha-dornase, and it's a drug that was developed for cystic fibrosis to thin the mucus. And in cystic fibrosis, they know certain characteristics of the proteins in the mucus. When trials were done to look at the use of Pulmozyme in non-CF bronchiectasis and other lung situations with thick mucus, it did not show a benefit, and it's an extraordinarily expensive drug. So we don't use Pulmozyme in non-CF patients generally, but we do use hypertonic saline, which also was first developed based on observing CF patients who were surfers seemed to do better because they were on the beach with the salty air. And so we certainly have adapted and used hypertonic saline to thin mucus in a number of different patients. And I have people, for example, who have severe cerebral palsy that have impaired cough clearance, and we'll use hypersal with them.
Okay, thank you. We've had a lot of discussion around different drugs and pharmacologics to help. Can you comment on prolonged QT syndrome in some of our children with Rett syndrome, and any risks that you know of with any of these mentioned pharmaceuticals?
So the prolonged QT syndrome is an electrophysiologic problem where the signals in the heart follow a specific electrical pattern of how they kind of move through the heart and cause the beating of the heart and the regularity of beating. So this QT is on an EKG, kind of an interval that's described. And if it's long, then it could give you more risk of arrhythmias. There are drugs that are known to prolong QT, and there's a variety of them, and some are more likely or not. And really the ones that certain drugs, like a nausea drug called Zofran, might do it. There are some antibiotics that can prolong your QT, and it's not really a list that's easy to just recite. One would have to look into it. The things that I mentioned generally for airway clearance and saliva control and all, they're not involved in prolonged QT. And, you know, typically if I'm going to start some new medication, I certainly check drug interactions, or I circle back. We have a PharmD at our hospital. I can always call her up and say, here's what the kid's on, check this out, tell me if there's risk. Occasionally, when we have a person who has prolonged QT, but we have a medication that we feel we really need to try for them, typically what I've seen done is that we get a baseline QT measurement, they go on the medication, and they repeat ECGs, the EKG, in days to a week to see if there's a worsening, and if there is, obviously we stop it. If it's stable, then they monitor it.
Great, thank you. And I know this might a little bit outside of the scope of this presentation, but it is recommended that our children be checked for prolonged QT syndrome at least once every 1 to 2 years, because it is something that can surface throughout your life, and you know, is not a one and done type of test.
Right, but it's a good point. If you know, if you're working with a different provider, obviously you'd like to know that I've looked at their medical record and things, but bring up things, well, you know, they have prolonged QT, is this medicine okay? Or, you know, she's on these seizure medicines, is this okay with those? It's always reasonable to ask. And the same thing goes for over-the-counter medicines. Don't just pick things up and give them. You can take them up to the pharmacist and say, can you check if this is okay with my child? And a pharmacist should be able to give you some guidance, or they'll tell you that they're not sure and you need to go check with your physician.
Great, thank you. That's a great recommendation. I'm going to move on to the next question in the queue. A parent is asking if you believe that all dental sedation should be hospital-based, even if their child doesn't have significant breathing issues.
So I actually don't get asked that question very often. So I circled with Dr. Glaze, who's the head of our Rett Center, and asked him, and that's his advice. I think, again, to some extent, you're weighing risk and benefit and access. So I certainly know that our dental clinic at our hospital is oversubscribed, very busy. I think for an individual, you need to really circle with your neurologist or your Rett doctor and say, you know, my child, what do you think? And it depends probably too on how extensive the dental work, what kind of sedation, because some sedation is more at risk for more suppression of breathing versus perhaps something that's just a very mild anti-anxiety medicine.
Okay, thank you. I hope that answers the question. This question, I think you answered already in your presentation a couple of times, but just to hit on it again, this attendee's granddaughter was placed on Topamax by her Rett specialist in the hopes that it would decrease her hyperventilating, and it seems to have done so. Really the question is if there are any other medications that you think would normalize her breathing pattern. If you wouldn't mind just repeating your answer, that would be fantastic.
And again, that I circled back with some of my colleagues in neurology who do this really more to see what they were using. Because if you go to the literature, and even like that survey of the 213 parents, they ask how many of the patients were being treated. And actually a minority of patients were on anything, but all of these various things have been tried, and probably some other things. And I think it's really, again, kind of a judgment based on somewhat the pattern and how much of an anxiety component perhaps there is, what other seizure medicines, if they have seizures, are they on, things like that. And so the Bisperone is one of the ones that we kind of go to most often because of its safety and its sort of anti-anxiety properties. But it's not the majority of patients who are on any treatment. Most of them, the breath holding is just something you kind of take note of and put up with because it's usually not that dangerous or serious. It's just odd.
Okay, thank you. Mysteries of Rett syndrome. Okay, we have another question. This is a good one. So during respiratory illness, it's not uncommon for their daughter to have respiratory rates of 100 or over. Is this strictly related to the respiratory issue, or could there be an overlay of autonomic issues?
You know, sometimes when I describe these situations, I sort of say they do it with style. So I think, you know, if you have obstruction or pneumonia or you've got fever, you're going to breathe faster. And if you have some dysautonomia, you probably are going to, it's going to be exaggerated a bit, but certainly that's a very fast breathing rate, and I'm sure not comfortable to watch. And at least you know, someone needs to be saying, is there some component that requires some different treatment or support? Or, but I expect that the autonomic stuff does kind of magnify their reaction to fever, or their reaction to stresses or respiratory challenges.
Okay, thank you. Okay, next question is there any evidence, even anecdotal, that breathing patterns change in Rett patients over time? And if someone has a woman, an adult child with Rett syndrome who hasn't had breathing abnormalities most of her life, could they appear in adulthood?
I think you know, just as seizures and other things can appear at any time, there is some description that actually the breathing problems seem more, or the irregular breathing is a little more common in the younger children, and it may actually be a little less evident in the older patient, whereas like the air swallowing and bloating tends to be a little more in the older patients. I don't know why that difference occurs. I think too, again, because there seems to be some variability, and I've certainly had people that say my child very rarely does any breath holding, but then some stressful event or something changes and they may have it more, and then things settle down. So I wouldn't say that it's impossible to have it develop at a later age, but I think if anything, they see it perhaps more in the younger kids.
I would agree with that observation. Thank you. Just quick housekeeping. We are at the top of the hour. We are planning to go for about another half hour. So if you have additional questions, please type them in to the control panel and we'll get to them. We have about 3 or 4 more hanging out there. Dr. Sockrider, the next question is, can you discuss the ramifications of metabolic acidosis for our children?
So metabolic acidosis is not what is in contrast to respiratory acidosis. So first, if you are not breathing effectively, like you are hypoventilating and your carbon dioxide level goes up, that causes a respiratory acidosis because the carbon dioxide is an acid that's building up in your blood. And so if I have a metabolic acidosis, which is due to some other problem, whether it be a drug effect or a kidney problem, I typically, am going to respond by breathing faster and deeper to try and help my body to stabilize that acid by blowing off more carbon dioxide. So if the lungs aren't working well, the kidneys sort of jumps in to help by managing more bicarbonate. If the kidneys or some other part of the body's causing a metabolic acidosis, then the lungs are supposed to kick in, and you'll see someone breathing faster and deeper because they're trying to blow off carbon dioxide to compensate for that other acids in the blood. And I guess that's what they're looking for, an answer. I really don't know how commonly we see metabolic acidosis. It's not something that I've been really involved in taking care of, but that is how the body's supposed to compensate.
Mm-hmm. Okay, just wanted to remind everybody that the recording is ongoing, and you can absolutely be able to reference back. We did have a question from a parent, though, whose daughter is on a ventilator, and he's got to leave in a few minutes. So I want to give him a chance to hear your response live before he has to take off. So Dr. Sockrider, for this particular family, their 8-year-old daughter has been on a ventilator for the last 40 months and sprinting now for about 8 hours a day, which is a good sign that she might be getting off the ventilator. Her CO2 levels and everything are okay. And she had started sprinting about 5 minutes a day, and now she's up to 8 hours. So he'd asked the pulmonologist not to stop sprinting when she falls asleep, since, due to Rett syndrome, her sleeping patterns are so irregular, and she tends to fall asleep about 5 minutes after the sprinting starts. So after asking the doctor to ask all the respiratory therapists to continue the sprinting, even if she falls asleep, their daughter's been doing really good, and they've been increasing 15 minutes a week, up to 1 hour for about a month now. And they just wanted to know, in your opinion, is this a good sign that she might be getting off the ventilator soon? And what are your thoughts on how they're progressing here?
So certainly there are other factors that play into one's ability to breathe well on their own, and perhaps some of those things also have improved. So for example, someone who's been very ill with a critical illness, if they're malnourished, they're weaker, and they're not going to come off a vent. If they have other problems like pneumonia, or they've had poorly controlled seizures. So if other things are stable, then it is a process of helping someone sort of work on taking charge of their breathing, sitting up more. We talked about earlier, you breathe more effectively than lying down, and so getting her up in her chair, her wheelchair, whatever, or sitting her up more can help. Certainly I see people who, and as we have children of, for whatever reason, they are vent dependent, we often try and work particularly to get them off during periods awake, because typically when you're awake, you're breathing more deeply and you're more often upright and things that would help your breathing. And it's when more other activities of life are going on, enjoying things around their environment, working on physical therapy. And so we often prioritize awake times for being the times that you're really giving them less support with the ventilator. We're always watching carbon dioxide levels and oxygen saturation. And so when I have a period of time that the person's either on less support or off their support, we may check, a gas at the end of 4 hours to see, are they starting to wear out? Because sometimes people can really wear out quickly or obviously, and other times it's like they kind of dwindle and you don't realize until the crash, or they may do fine for 2 days and then they just wear out. And so kind of keeping tabs on that ventilation. It is true, as we talked earlier, that people with Rett syndrome, if they have funny sleep patterns and you write an order for the nurse, use vent during sleep, and then they take a nap in the afternoon, or they sleep little cat naps. It's a little tricky. And I think some of that has to do with kind of thinking about, too, what their pattern of sleep is. And we talked about sleep stages. The deeper sleep stages are when your breathing is the least efficient. And so at night, when people need a good long rest, they may need or benefit from that vent support to get better support, to have more effective breathing. Whereas a short nap in the day, they may actually not go into a deep REM sleep and they may actually breathe okay. And so I think it isn't necessarily bad to continue to kind of make progress. The other thing that we do at times is there's sort of full vent support settings, and then there's no vent support settings, but there's also kind of intermediate where you might just use a little pressure support to kind of give them a little bigger breath. And again, it's still some support, it's still hooked to a machine, but sometimes that little boost of support kind of helps them keep working on their respiratory strength, stretching those respiratory muscles, and giving them a longer time off full support. And it's a very individualized process. There's no rule book. There's no like, okay, give them 2 hours, now go to 4 hours. It's all about that individual. And then any road bump, if they get a pneumonia or they get something else that comes up, may set them back again.
Okay. Thank you. I hope this helps parents navigate this process, and we certainly wish them luck. I think they're having to leave the call at this point, and to our attendees, if we don't get to your question today or you don't get a complete answer, please submit it into the text box before you take off, or email me privately, and we'll make sure that all questions do get addressed.
I would say that it's very difficult to give advice specific to a child because there's medical information and there's knowing that child, and also I am happy to give general answers or sort of guidance or tips, but to come to a very specific question about an individual child is not really fair or feasible or at your child's best interest. But I will do my best to try and give some clues or questions to ask your healthcare providers.
It's a really good point. Absolutely. Every individual deserves attention from a knowledgeable, experienced provider who knows the child and his or her health history. And during any of our webcasts, all information presented is general information based on experience and really shouldn't be taken as gospel for an individual child. But I love how you said that you're willing to offer questions that perhaps could be taken back to their individual provider. Thank you. If I can move on to the next question. This parent, their daughter has recently started to exhibit dystonia in her jaw, especially while eating. Do you think that this could be related to breathing and swallowing issues? And any suggestions if so?
Well, certainly dystonia in the jaw could affect one's ability to chew or swallow. I don't know if this is a bit of a chicken and egg. If they're having other swallowing problems and they think they're compensating in an awkward way that's affecting the jaw. But and certainly our physical medicine and our neurology folks are the ones that kind of think about treating some of these kind of dystonic things. Trouble with medications that have to do with spasticity or dystonia at times is you kind of don't get to choose which muscle groups they work on. Now that's different if one is thinking about Botox injections, like some of our patients with spasticity get, but you can't go, okay, I want you to go to the arms and legs and leave that throat alone. And so I always, say that if there's a change, one should circle back again to, is there some medication that needs to be thought about, whether it's causing it or whether it might help it. And people who, you know, we mentioned silent aspiration, which the only clues for that are really the side of the complications. My child always has a chronic cough. I have chest congestion, and I don't know where she got it from because nobody else is sick. Things like that, versus really the recognition of people who are having swallowing symptoms and their airway is reacting, that they're choking when they eat, or they're having more cough after they eat, etc.
Mm-hmm. Okay, and who would be the specialists that you'd get involved? You mentioned neurologist, physiatrist. Is it a physiatrist?
Yeah, I mean, I always sort of depend on the neurologist kind of being the director or the gatekeeper, but I know that our physical medicine and rehab doctors are often involved as well, and they are also the ones who do like Botox treatments and things like that. So PM&R is another kind of group that thinks a lot about dystonias and spasticity in concert with the neurologist.
Okay, great. So we're moving into the last 10-15 minutes of our webinar. So again, if you have a question for Dr. Sockrider, now's the time to get it in. Let me ask you another question from the queue. So this parent, their daughter wears a BiPAP at night for obstructive sleep apnea with a nasal mask. However, she has challenges with closing her mouth due to jaw position. Do you have any suggestions for that? Perhaps a mouth guard or something else that would help?
Yeah, you know, it's the nasal masks, and there's different kinds, and everybody's face is a little different. So sometimes the first trick is to find the interface. We call it the mask that fits the best. And there's nasal pillows as well. And there certainly are people who are mouth breathers, and then you're always going to have some leak of air that comes out through the mouth. And sometimes you can just compensate for that by adjusting the pressures. There are chin straps that are used at times, but there's always a little bit of concern that if someone needed to vomit, for example, and they had a chin strap and they couldn't take it off themselves because they didn't understand how, or they couldn't do it, that they would be in trouble. And some families, you know, if their child is on CPAP or BiPAP or a ventilator, they've got a nurse there at night, and others, whether they choose or they just don't have that resource, may not. There are full face masks, and I certainly have people who use full face masks at times, although again, that same concern of do they need to get it off? I mean, people don't vomit, thankfully, that much, but that's the kind of, in theory, the risk. I'm not sure there are various kinds of mouthpieces, mouth guards. I guess people talk about that some with teeth grinding and all too, and I am not as familiar with those. There are sleep physicians. Some of them are neurologists, some of them are pulmonologists. Some of my colleagues have special training in sleep, and that would be a person you could talk with more.
Great, thank you. I've experienced it with my own daughter, and I've heard it commented on many times that for girls and boys, for kids who have very little hand function, sometimes it's really amazing what they can come up with when you're trying to keep a mask on.
Oh yeah, Houdinis they are. Yeah, it is amazing how they can, I don't know, even just wiggle their face and all. But yes, it is true.
Yeah.
I will say there are definitely people though who, when they get their I mean, you would just uniformly think no one could stand that, but there really are children and people who they kind of realize they sleep better and they get used to it. And I have known patients who, you know, they expect mom to put it on. So I don't think that it's always a struggle. And if one has trouble like with nasal allergies and all, one is humidifying the air. So a dry air is going to bother your nose more. Some people, though, may need treatment for like allergic rhinitis, whether with antihistamines or nasal steroid sprays or something like that to tolerate their PAP therapy better.
Mhm. Okay, this is the last question in our queue right now, unless someone wishes to submit another one. And I think this is a good one to revisit. It was a parent who joined the call late and apologizes if you've already talked about this, but in big capital letters has asked for help with air swallowing and burping. And I know that this is such a big problem for so many of our girls. Can you revisit the that particular breathing pattern that is pretty common in quite a few girls who do a lot of air swallowing, have a lot of burping, consequently can have some vomiting, and what are some ways that might help decrease it?
Yeah, actually, I have to confess, I don't usually get involved in treating that either. We have a very capable gastroenterologist, Dr. Motil, who works and really, I mean, she is very protective of her Rett patients and their program. Certainly people with a G tube, they talk about venting the tube. And in fact, some people may have one of the utilities of having a G tube is the ability to use it to vent. I think there's been various medications that are used kind of to try and help manage the gas going through, whether it be a motility agent like bothanicol or anti-gas things. I don't have a good sense of what he typically uses most. I've seen some of the patients be on drugs that help with gastric emptying, like erythromycin. But I think you have, Doctor, don't you have a GI talk coming up in the future?
We do. I was going to say this is a great plug for Dr. Motil, who will be our guest speaker on April 10th.
Dr. Motil will have a great deal to say, I'm sure, and I'm sorry that I could have, I guess, circled with her too ahead of time, but I think there are ideas, but it is, again, another one of those things where it's a bit of trial and error to see what works best for that person.
Yeah, I agree. And there's a lot of system-to-system interaction that we always have to think about with Rett syndrome. And I appreciate that you said that oftentimes our neurologists are the ones who, if in a sense, quarterback a lot of these issues to say how are seizures influencing breathing and how are medications for breathing perhaps affecting digestion, and when should a physiatrist help with dystonia and all of those things that can then interfere with breathing.
Yeah, so, we really work as a team, and who is evoked and who the patient needs to see is really orchestrated by their primary Rett doctor, and whether it's a neurologist, whoever, and frankly, it's the same model that we use in cystic fibrosis. So I take care of a lot of the digestive problems of my patient, and then I decide who needs to go to my CF GI specialist, because a lot of it is we can handle easily, but I know if I need them or I need the endocrinologist or whoever I need, then I've got to pull them together, and then we kind of work together as a team so that you're getting the best combined advice that takes in mind the other medications, the other strategies that you're trying. So.
Yeah, and to follow on with that, I would just really encourage everybody to take the time to visit a Rett Center of Excellence. There may not be one right in your backyard to utilize for everyday care for your child, but to get to one of our Rett clinics gets you through the door and having this kind of team approach to solving a lot of the issues that our girls and women and boys face every day. And those teams, once they meet you and your child and talk through some of the issues, can make recommendations of other experts to pull on and be a part of your team. I know these appointments can be very overwhelming and hard to make, but I think everybody at our Rett centers, Dr. Sockrider, a great example of someone who is not seeking to overtreat, but is absolutely there to help with any intervention that could help with things that are getting in the day-to-day for our kids.
I might
So
add
as we
that there are patients that I see regularly that I'm, that we work together and see each other, maybe even 3 or 4 times a year. There are other times where someone's coming into our Rett Center from out of town or out of the country, and they try and think about what are that person's interests or needs. And I may see someone, and I always try and advise them, you don't want too many cooks. On the other hand, if I can offer some tips or just as a second opinion of here's some things that you're doing or you're not doing that you might try, and circle back then with your local pulmonologist, then, that's certainly a role that we're willing to provide. But it does then take sort of then coming back to your local team and saying, and alerting them that, hey, there's this resource that we can go and talk with the Rett Center, and they're willing to give you ideas. And I would think that most pediatric providers certainly are open to that kind of collaboration.
Mm-hmm. I think so. And I think having access to this recording from today's webinar will be a great help in helping, some of us who aren't so comfortable talking to our doctors and don't know doctor speak can pull up this recording on your smartphone when you're in for an appointment and replay a certain part that really piqued your interest or you'd like to have more information about. And as Dr. Sockrider said, if your care provider is really good and has your family's interest at heart, they'll take the time to listen to Dr. Sockrider's comments and then discuss the course of planning for your own particular child. And that's really how we want you most to use this information as a springboard for discussion with your own doctors. So Dr. Sockrider, in closing, do you have, in reflecting back on the questions that were asked today, the different themes that have come up, do you have any closing thoughts to share with our audience today?
Well, certainly, I respect that there are so many different challenges with Rett syndrome, and I know that people are always trying to be sure that their loved one is as healthy as possible. And I also, certainly being a pulmonologist, know that breathing is so important. So it is kind of unnerving when you see funny breathing patterns or you worry, are they breathing well? I think thankfully most of these are manageable symptoms that don't cause as much disability as we might fear, but every person is an individual, and that's why it's so important to have a team that gets to know you and your child, and you try things and see how they go. And I wish you all the best.
Yeah, thank you. Thank you. That's a really important message. Your child is her own unique individual first, and Rett syndrome is something that she has. And it takes a team to sort of tease out those things sometimes. Well, thank you so much for your time. Thanks for a wonderful, very thorough presentation. We appreciate the years of really attentive, thoughtful care that you've provided to all of your patients that you've seen at the Texas Rett Center, and for sharing all of that experience with all of us across the country and around the world today. You give us hope, and we're really lucky to have you as a partner on this journey. Thank you so much.
You're welcome.
All right. Well, for our attendees, I hope you found value in today's session, and then the knowledge that you learned here today will help empower you on your path forward. And at rettsyndrome.org, we truly believe that information on our rare disorder should be free to all who avail themselves of it. So we really want to thank our donors who support our foundation and allow us to bring webcasts such as these to your smartphone, to your smart devices, so that you can learn and be the best advocate you can for your kids. This also allows us to direct as many precious dollars towards ongoing research, and the research that we're working on, really our goal is to come up with treatments in the here and now for today. Prime example is the STAR study, the Sedation clinical trial. We really wish that great success. Your enrollment is what will help that research come to conclusion much faster. So after today's discussion, if you feel like your child could be a potential candidate for that clinical trial and you're interested, you'll find all of the information on our website and on the STARS study website. The URL was in Dr. Sockrider's slides.
Right there again, rettstars.com.
Thank you. Thanks. And expressing your interest doesn't commit you in any way to the study. It would just get you started on a conversation towards enrollment and screening. So don't be afraid to take a chance, and perhaps it's something that we'll all benefit from moving forward. So thanks, everyone. I hope that you join us next month. Our topic next month is on puberty and issues in adulthood. We will be welcoming Jane Lane, a nurse practitioner at the University of Alabama at Birmingham, who's taken a particular interest in puberty and adulthood issues, and that should be a great session for everybody, moms, dads, grandparents, anyone who is looking down the road or is already there will find some great information on that this next webinar, and you can register for it by visiting rettsyndrome.org/RettEd, RettEd. So in the next day, you'll receive a follow-up email from today's call that will have a link to today's recording. Please feel free to share it with anyone who missed the call or that is on your child care team who would benefit from learning the information. Go back and listen to it again. I know that I benefit from hearing things 3, 4, and 5 times. I always pick up something new. Thank you so much, Dr. Sockrider. I know you have to get back to clinic. We really appreciate your time today, and we will talk to you soon. Thanks, everybody. This now concludes our webcast.